Hello everyone, my name is Kuldeep Man. I'm a former body imaging fellow at MGH, and for the next 3 minutes, my topic of discussion is ileocecal endometriosis, a retrospective observation study. I have no relevant financial disclosures. Ileocecal endometriosis is a rare diagnosis with only 4% of the patients with deep endometriosis affecting this area. Our study design consisted of 16 female patients with histopathological, laparoscopic, or imaging diagnosis of ileocecal endometriosis. The study design was retrospective. The key imaging features was T2 hypertense nodular or concentric bowel wall thickening with obliteration of the normal T2 dark muscularis propria. This is a case example of ileocecal endometriosis. There is a T2 hypertense concentric thickening in the ileocecal region with the soft tissue density seen on the CT. The gross specimen showed a focal bulge in the same area with a cut specimen demonstrating deep endometriosis. 20% of the patients in the study pool presented with acute bowel obstruction. This is a case example of bowel obstruction with a soft tissue mass centered in the ileocecal region with upstream bowel dilatation. The key association from our study was 69% of the patients were classified as AAGL stage 4, reflecting advanced endometriosis. 69% of the patients had at least one endometrioma. 81% of the patients had concurrent sigmoid colonic endometriosis, with 75% of the patients had rectosigmoid junction endometriosis. 75% of the patients had prior history of pelvic endometriosis, and 19% of the patients had prior surgeries for endometriosis. When we analyzed our data pool, we learned that only 38% of the patients were preoperatively diagnosed correctly. And there were many reasons. Number one, it can mimic a number of different pathologies, all the way from malignancy to Crohn's disease or TB. Secondly, there are a lot of technical and anatomical factors, such as the ileocecal region is quite mobile versus rectosigmoid junction is more fixed. There is bowel peristalsis associated with small bowel, which can cause motion artifact. The ileocecal region may not be covered completely on a standard pelvic MRI. And thirdly, there is low suspicion for ileocecal endometriosis to begin with because the rare diagnosis can present with non-specific symptoms. And sometimes when there is extensive pelvic disease, it may divert our attention from the ileocecal region. So given these study findings, we proposed a modified pelvic MRI protocol for all patients with endometriosis, where we would include a large field of view coronal T2 haste and fat suppressed T1 weighted sequence extending from the diaphragm to the iliac crest. Any abnormality seen on this standard pelvic MRI in the ileocecal region can then be confirmed with MRE or CTE to confirm the diagnosis. Thank you.